Welcome everyone, and thank you for joining us for the first lunchtime webinar of the new academic year. We started these a year ago in the hopes of giving alumni and friends ongoing access to some of the research and thinking here at the school, and we are gratified by the enthusiastic response. These webinars are designed in part to be lecture and part discussion, so we will allow plenty of time for questions. If you do have a question, simply type it in the field at the bottom of the chat window. Also, please feel free to give us feedback using the emoticons. Our topic today is health benefit exchanges, one of the crucial elements of the Affordable Care Act. The responsibility for developing and operating these exchanges falls primarily on state governments, which so far have demonstrated varying degrees of support. In this webinar, Dr. Gerald Kominski will focus on what the exchanges are supposed to do, provide an update on federal regulations governing exchanges, and provide a progress report on California's efforts as well as the efforts of states across the nation. So Jerry, take it away.
Thank you, Carla. It's my pleasure to be with you today to talk about this important component of healthcare reform. So let me, without any further delay, jump into the topic. So what are health insurance exchanges? It's interesting. Over the past 18 months, as I've had a chance to talk with various audiences about ACA and health reform, this is a question that comes up quite frequently, and the historical sort of basis for health insurance exchanges really goes back to Alan Enthoven, who proposed in the late 70s that the Federal Employees Health Benefit Program could be a model for health insurance exchange, and he actually based his proposal for national healthcare reform on a managed competition approach that resembled what currently exists and has existed for decades in the Federal Employees Health Benefit Program. Enthoven called these health insurance purchasing cooperatives, and that was sort of the what we thought of as exchanges for probably about 2 decades. And for those of you who remember the Clinton attempt to revise health insurance in the U.S. HIPAAs were an important component of the Clinton proposal for health reform. But basically, the rationale that Enthoven laid out over 30 years ago for insurance exchanges, or as he called them, HIPAAs, is that Enthoven thought that the biggest failure in the market for health insurance was the lack of power on the part of purchasers. So Enthoven proposed to balance the market power that is held by insurers on the supply side of the market by concentrating purchasing power of buyers on the demand side of the market. And basically, Enthoven's analysis, and I think that it's still relevant today, is that when there are inequities on one side of the market or the other, that's when markets don't perform well. And because it's difficult to do away with concentration on the supply side of the market for health insurance, that the counterbalance was to concentrate the purchasing power on the part of buyers of health insurance. And that was really the economic rationale for the purchasing cooperatives that have now evolved into health insurance exchanges. And if anybody's interested in reading more about Enthoven's approach and the history of this idea, there's a good Health Affairs article that was published in 1993 that's referenced on the slide. I highly recommend it. What are there health insurance exchanges out there already? And I think the answer is yes. I mean, we've been living with these in various forms for several decades. I already mentioned the Federal Employee Health Benefits Program, which has been in existence for over 30 years, probably more than 40 years now at the federal level, and provides a mechanism for federal employees to purchase health insurance plans that compete on both price and benefits, with subsidies from their employer, in this case the federal government. In California, we've had an exchange for decades under CalPERS, and CalPERS basically operates an exchange for California municipal employees. I think that broadly defined, Medicare Part C and Medicare Part D can both be described as health insurance exchanges. They are managed markets for private health insurance where Medicare beneficiaries can go, in the case of Medicare Part C, to buy a managed care product as an alternative to fee-for-service or traditional Medicare. And in the case of Part D, to buy prescription drug coverage, again, in a regulated market with subsidies from the federal government, but basically purchasing private insurance in a regulated market. Now, I think this audience is clearly aware that the Massachusetts Health Reform Bill was the basis for the Affordable Care Act, and as a result, the Massachusetts Health Connector obviously was a model for the Affordable Care Act, and is an exchange that's functioning much the way we expect other state exchanges to function. But I'd also like to point out that in terms of exchanges, that essentially exchanges will resemble what large employers have also been doing for a number of years. And any large employer that offers multiple health insurance plan during an open enrollment period is essentially operating an exchange for their employees. And of course, the exchanges on the Affordable Care Act are targeted to a different audience or different constituency, but certainly large employers that do offer multiple policies effectively are operating exchanges for their employees already. So just to review the provisions of the Affordable Care Act and where exchanges fit into the bill. The bill establishes state-based insurance exchanges, and it allows for 2 exchanges in each state: an individual market exchange for individuals and families who are uninsured, and qualify for premium subsidies, and a small group market exchange for employers that have 100 or fewer employees. The law allows for the small market exchange to be open to large employers starting in 2017, and it also allows for co-ops and a quote-unquote public option to compete with private insurers within the state-based exchanges. An essential requirement, or an important requirement of the bill, is that it allows only qualified health policies or plans with essential health benefits to be sold both inside and outside of the exchanges in 2014. The only exception is grandfathered plans with non-standard benefits that can still be offered outside the exchange but not inside the exchange. With regard to premiums, the law regulates how premiums will be set. Premiums starting in 2014 will be set using modified community rating, and the only factors that can be taken into consideration in determining rates are age, where premiums can vary by no more than 3 to 1, tobacco use, family size, and geography. And of course, the most important omission from this list is health status, which can no longer be used in setting premiums, except again in grandfathered plans. The bill allows the existing small group and individual insurance markets to continue to exist outside the exchanges, but outside the exchange, insurers must charge the same premium for policies with an essential benefit package inside and outside the exchange. So new policies starting in 2014 will have to comply with the essential benefit package requirement, and if those plans are sold outside the exchange, insurers will still have to charge the same amount if they offer that same policy inside the exchange. And I'll talk more about what California is doing in this regard a little bit later in my presentation. The Affordable Care Act also, as an essential component of these exchanges, calls for the creation of a standard health policy. It establishes qualified health policies all having the same essential benefit package. And the language from the bill says that the Secretary shall ensure that the scope of the essential health benefits is equal to the scope of the benefits provided under a typical employer plan as determined by the Secretary. And at a minimum, there are 10 categories of services identified in the bill. It must include mental health and substance abuse services, prescription drug coverage, and pediatric oral and vision care. So all essential benefit packages have to include those services as well as the others specified in the bill. And I call attention to these 4 categories here simply because many insurers currently do not provide all of these benefits or as essential health benefits. It establishes 4 tiers of qualified policies based on the actuarial value of the premiums. So these are now widely known as the metal plans or the metal tiers, and the lowest tier being bronze, then silver, then gold, then platinum. And just remember that the only thing that differs here is how much is the actuarial value. And just to remind everyone, the actuarial value is the average expected amount that premiums in the aggregate will cover versus out-of-pocket spending. So the difference between a bronze and a silver plan is not the benefits that are covered, but the expected out-of-pocket cost on average. In the bronze plan, on average, 40% of the cost or total expenditures under that policy will be out-of-pocket versus 30% for silver, 20% for gold, 10% for platinum. The catastrophic policies are available only for those under age 30, and this is really targeted at what are commonly called the young invincibles and young adults who are otherwise uninsured will be eligible for catastrophic policies. All qualified policies starting in 2014 have to have annual limits on out-of-pocket spending. And those limits are $5,950 for individuals and $11,900 for families. There are lower limits for those below 400% of poverty level, and I'll show you a chart in a minute to show you how that's going to be operationalized. All policies in 2014 have to guarantee issue and renewal, and have to eliminate lifetime and annual dollar limits on benefits. So that's just a review of some of the provisions that affect the exchanges. Let's turn to the next slide, and I will apologize to anybody that has a small screen and is viewing this complicated chart. But hopefully you'll be able to follow my sort of path through this chart. So this is a chart that I borrowed from the Kaiser Family Foundation, which I think does an excellent job of summarizing how people get into the exchange. And the most important pathway is the one that's on the left-hand side of this chart or figure. If you start up in the upper left-hand corner with a green area that says start here, the first question is, do you have employer coverage? If the answer is no, then you go down. Let me see if I can illustrate this with this path with the markers here. So starting here, we go to, is employer coverage available? If the answer is no, the next issue or question is family income less than or equal to 133% of poverty? If the answer is no, in other words, you're above that 133%, the next question is family income less than or equal to 4 times the poverty level? If the answer is yes, then the individual or family is guaranteed access to insurance through the exchange and is eligible for a tax credit or a subsidy to purchase that insurance. And this is the pathway that we anticipate the majority of individuals and families will find their way into the exchange. But there are two other pathways that I do want to call attention to for people who have employment-based insurance, and those are illustrated on the right side of this figure. So for individuals who have employment-based coverage, if their family income is above the 133, the next question would be, does the employer plan cover at least 60% of health expenses on average? If the answer is yes, then the next question is, does the employee pay more than 8% of income for the premium in this employer plan? If the answer to that question is yes, and family income is less than or equal to 4 times the poverty level, there are two pathways for getting into the exchange. If the employee pays at least 8% and in fact pays more than 9.5% of income for the employer plan, that would lead to eligibility for coverage through the exchange and eligibility for a tax credit. And as you'll see in the slide that I'm going to show in a minute, the idea here is that even if you currently have insurance, that in the exchange, no one is going to pay more than 9.5% of income if their income is below 400% of the federal poverty level. So currently insured individuals are not going to be penalized and have to pay more just because they have employment-based insurance. For individuals who pay more than 8% but less than 9.5%, they too will be eligible for the exchange, but rather than being eligible for a subsidy, they'll be eligible for what's known as a free choice voucher. And that is that their employer would be required to provide them with a voucher equivalent to the amount that the employer is paying on that employee's behalf for health insurance. And the employee could take that voucher into the exchange as essentially a subsidy, but the subsidy is coming, in this case, from the employer rather than from the federal government. So although I realize this is a relatively complicated figure, I hope that that helps clarify the pathways that people will take in order to get into the exchange in 2014. And this slide I alluded to a moment ago, which is the premium and cost-sharing provisions under the bill. So you can see at different poverty levels for some individuals less than 133% who don't yet qualify for Medicaid. Single individuals, that threshold would be 14,484, families 29,726. They would pay no more than 2% of their income and would have out-of-pocket maximums equal to the amounts set here. All of this results in an actuarial value for any individual or family in this situation of 94%, which is another way of saying that on average, 94% of the cost of covered health benefits would be covered by their insurance policy or by their insurer. And you can see that as income increases, the percent of premium paid by families as a function of family income increases up to 9% at the highest end. You can also see that the actuarial value declines eventually so that it equals 70% for families above 250% of poverty. But I just wanted to use this slide as a way of indicating not only the out-of-pocket liability for premiums, but also the out-of-pocket maximums that families will face in the exchange. So let me turn now to some of the political climate surrounding the exchanges, and talk about and give an update on where we are nationally with regard to implementing healthcare reform. And this is also a complicated slide, but the color helps, I hope, clarify some of the confusion. But when you look at this map, I think the first thing that should hit you is that there are a lot of different colors here, and indicating lots of different levels of progress. So starting with the chart or the legend at the bottom, states that had exchanges in existence. There are 2 states on the map, Utah and Massachusetts, that had exchanges. Massachusetts obviously has an active exchange that's functioning much as we would expect under health reform. Utah's exchanges, although it predates the Affordable Care Act, does not provide a mechanism for subsidies, but it is an organized marketplace and web portal for individuals to and small businesses to buy insurance. The dark blue states on this map are states that have signed into law legislation authorizing the establishment of insurance exchanges, and you can see that there are the western states have all done that: Colorado, Illinois, West Virginia, Maryland, and Vermont, although Vermont actually is moving in a different direction with regard to a single payer system. But what I think is more striking on this map is the fact that there are a number of states where, now moving over to the right side of the legend, states that have pending legislation that failed, and this includes Arizona, Texas, Oklahoma, Missouri, Iowa, Minnesota, Maine, New Hampshire, and South Carolina. The states in orange where governors have pursued or are considering non-legislative options, which is another way of saying that the governors are not excited about moving forward with exchanges, but are keeping their options open. In green, we have states that have where the governor has basically either vetoed or decided not to pursue an exchange. And then 10 states in white on this map. There's not the legend doesn't indicate what those states are, but these are states that have essentially taken no action with regard to exchange establishment or creation. So I think that the conclusion that I draw from this map is it's obviously not surprising to anyone who continues to follow the progress of the implementation of the Affordable Care Act that there's tremendous variation across the country in progress towards creating what is an essential component of the reform bill, i.e. health insurance exchanges. And I think this is representative of the political conflict, that's the ongoing political conflict surrounding this legislation. But let me turn our attention now to what's going on in California, because California, in contrast to most of the rest of the nation, is moving forward much more rapidly with regard to implementing key provisions of ACA. California was the first state to establish an exchange when Governor Schwarzenegger signed 2 complementary bills, AB 1602 and SB 900, back on September 30th, 2010, establishing the California Health Benefit Exchange. The exchange is a quasi-governmental organization that will selectively contract with qualified health plans. The exchange is governed by a 5-member board that is serving, where the members are serving 4-year terms. 4 of those board members are appointed. One is ex officio. 2 have been appointed by the governor, and specifically by former Governor Schwarzenegger. 1 appointed by the Assembly Speaker, 1 by the Senate Rules Committee, and the Secretary of Health and Human Services, Diane Dooley, serves as an ex officio voting member of the board as well. The exchange has received a $1 million planning grant and recently received a $39.4 million implementation grant to begin the process of setting up the exchange here in California. The board has been meeting monthly since April of this year. I think the 5th board member was Dr. Bob Ross, CEO of the California Endowment, was the last member appointed a few months ago, so the board is complete now. There are a number of challenges facing the exchange board over the course of the next few years. Clearly, one of the most important challenges is establishing criteria and procedures for selectively contracting with insurers. The enabling legislation makes it clear that the exchange board has the authority to selectively contract, and as most people describe this as an active purchaser rather than a passive purchaser of health insurance on behalf of those who are eligible for the exchange. Operationalizing this is going to take a lot of work over the course of the next 2 years in anticipation of 2014. Another major task is coordinating eligibility with Medi-Cal and healthy families, as well as providing for continuity of coverage as income changes. There's a lot of concern that people's eligibility for Medi-Cal and then for the exchange will result in lots of churning, and it's going to be a challenge for the exchange, which is responsible for making sure that people get placed into the appropriate coverage for which they're eligible. This is going to require a fair amount of work on the part of the exchange to make sure that those transitions are as smooth and as seamless as possible. And this includes just establishing a process for verifying income with the IRS. This is going to be an enormous administrative challenge and probably IT challenge as well. A third major challenge facing the exchange board is establishing a fee on insurers to become self-sustaining by 2015. The ACA requires exchanges to be self-sustaining by then. And the question is, what is the level of support necessary to keep the exchange operational beginning that year and into the future? Another policy issue facing the California exchange is determining whether to collect premiums directly from individuals or to allow insurers to collect those premiums. And then finally, an issue which is, as an academic-based researcher as well as a policy researcher, one that holds particular interest for me is issues related to reducing adverse selection within the exchange, as well as between the exchange and the outside market, to the extent that that market continues to be a significant one. The ACA actually put several measures in place to try and address this issue, so it's not incumbent on the exchange board to necessarily deal with this, because the bill has already anticipated this as a problem. But specifically, California's legislation went further than the Affordable Care Act and requires insurers to offer all 4 tiers of plans, whether they participate in the exchange or not. So this is a departure from the requirements in ACA and an example where California law went further. Furthermore, California's enabling legislation requires insurers to participate in the exchange if they want to offer the catastrophic plan for young adults less than 30 years of age. And this is specifically designed to prevent insurers from staying outside the exchange and trying to cream skim a young and relatively healthy portion of the population, and then allowing others to more older or severely ill individuals to seek their insurance in the exchange. There are provisions in ACA for risk adjustment, and the federal government, it will make risk adjusters available to the states that will be applied to insurers for members both inside and outside the exchange. So there's basically going to be software made available by the federal government for California and other states to use to assess the distribution of risk within and outside the exchange, and then to allow for the state to redistribute money between insurers to account for the fact that there might be differential risk enrollment, despite all the other efforts to try and prevent that from happening. And then finally, the other measure that's in the law is that insurers must charge the same premium inside and outside the exchange for the same plan. So that bronze plan the premium has to be the same inside and outside the exchange, again, to prevent any type of cream skimming from going on. Now, I mentioned that California's enabling legislation went further than federal law, and one area where it went further was to provide the option for the exchange board to require insurers to standardize policies within each of the tiers. And that standardization would include setting the level of copayments and deductibles, so that not only would, for example, there be a bronze plan that everyone is offering, but a bronze plan with a standard set of copayments and deductibles that all insurers would have to offer. That standardization, and the purpose of that standardization would be to make comparison shopping even more easy for purchasers by making clear apples-to-apples comparisons between plans possible. The board has that option, has not to date acted on that, but that will be an important challenge and policy decision that the board will have to make before 2014. Before I conclude my prepared comments, I'd just like to show you what we at UCLA, in collaboration with colleagues at the UC Berkeley Labor Center, think is going to happen with regard to California's insurance market as a result of the Affordable Care Act. And you can see in this slide we've produced estimates which we presented to the Exchange Board back in May about the changes that we expect to occur in the insured and uninsured population in California. Now, we produced estimates, and I'm showing you estimates here for 2019, and the reason for that was that this allowed for full implementation of all the provisions of the bill, including the taxes on so-called Cadillac health insurance plans that go into effect in 2019. So what we're estimating here is the impact of the provisions that will be in effect in 2019, as opposed to, say, projecting forward the population into 2019. So we're taking the policies that will be in effect at that year, but applying them to essentially California's current population. So what you can see in this slide is that we actually expect there to be some reduction in overall net employer-based or employer-sponsored insurance, partly because of the the Cadillac tax, and partly because we expect at least some employers, primarily small employers, will allow their employees to go into the exchange as opposed to continue to provide insurance coverage. We expect an increase in Medicaid enrollment of about 1.6 million. Relative stability in the Healthy Families Program, at least no net change. But I want to focus on the bottom three lines of the slide. So we expect that about 2.4 million Californians will be not only eligible for the exchange subsidies, but will actually be participating in the exchange. There are another 2.0 million Californians who we expect to be insured, but not eligible for exchange subsidies. And although we don't know, and we're not really able to estimate whether or not those 2 million insured will be in the exchange or not, they're not precluded from buying their insurance in the exchange. We have reason to believe that given all of the changes that I've talked about in the last 10 minutes about trying to equalize the markets inside and outside the exchange, that a large percentage of these individuals, even though they're not eligible for subsidies, may in fact find the exchange a better place to buy their insurance for other reasons in addition to price. The net impact we expect of the Affordable Care Act is to be a reduction of about 2.8 million in the number of uninsured in California, and leaving a point-in-time estimate of about 3 million uninsured, down from 5.8 million today. These are largely individuals who are undocumented and as a result not eligible for exchange subsidies or enrollment in Medi-Cal. But this also includes individuals who are currently eligible but not enrolled in public programs, and there are approximately 800,000 Californians today who are eligible for either Medi-Cal or Healthy Families who do not participate in those programs. And we expect that population still be difficult to reach. So let me wrap up my comments here. For more information, you can go to the Kaiser Family Foundation website and the Commonwealth Fund. And I also recommend you visiting the California Health Benefits Exchange website as well, although there's less information there now than I think there will be in the future. So thank you very much for your attention, and I think we'll open up the floor now for Q&A.
Yeah, thank you so much, Jerry. We do have time for questions. If you have a question, please type it in the field at the bottom of the chat window. And Stephen has already typed in a question. He wants to know what income is being considered for the subsidy levels. Is this going to be the adjusted gross income from the federal 1040 or gross wages?
The income is what's known as modified adjusted gross income. So it's essentially the adjusted gross income from income taxes. The modification, I can't remember off the top of my head what the modification is, but yes, it's essentially what's reported on income taxes. And that's why the IRS is going to be, why the state will have to verify with the IRS what that modified adjusted gross income is for an individual.
And Alex is asking if the presentation will be available. Yes, it will be on our website, the School of Public Health's website, in a couple of days. But Jerry, while we're waiting for other questions, perhaps you could talk a bit about what's required in the essential benefit package and how much discretion insurers will have to vary the benefits.
Yeah, I think that's a really good question, and we don't quite know the answer to that yet. It's right now probably the biggest most important, I should say, unknown about the reform bill. The Secretary has the authority to determine what the essential benefit package is, and the Secretary has asked the IOM to establish, or asked, I should say, the IOM to establish a consensus panel, which has been meeting, and it's my understanding that the IOM panel will be issuing its recommendations on an essential benefit package sometime soon in the early fall. I mean, it's already, September's almost over, so I anticipate that the IOM recommendations will be seen relatively soon. So the question is going to be, within the framework of the law, which identify 10 categories of services, how specific is the IOM consensus panel going to be with regard to the scope of services within those 10 broad categories? Are they, for example, we know that inpatient hospital care is an essential benefit and will be covered, but will that mean 365 days of inpatient hospital care for all health insurance policies? I don't think anyone knows right now, other than that people who are sitting on that committee, where they are likely to come out with regard to the specificity of the level of benefits within these 10 broad categories. So everyone is anxiously awaiting the report of the IOM committee, and this is really going to set the stage then, depending on how specific they are, for potentially lots of variation within those 10 broad categories of services, which would allow insurers lots of discretion.
We have a question from Gretchen. She wants to know how many people it will take to staff the exchange in order to do the administrative functions required to determine eligibility. That's a good question. I looked quickly at the proposal, the proposal that led to the state receiving the $39 million grant. There are a lot of staff positions in there. On an ongoing basis, I think that the exchange is going to have to work with county and local governments to establish enrollment and eligibility verification systems. So I don't know what the staffing level is going to have to be at the exchange, because I think that at least part of their job will build on existing capability in state, county, and local government agencies. But clearly there's a task here that no one's doing right now, and that is communicating with the IRS and on a regular basis to determine income verification. That is not being done today, and is going to require staff both at the exchange board level as well as at the federal level. John wants to know when the new law is implemented, will the insurers be forced to take all applicants irrespective of previous lack of insurance?
I think the answer is yes. The requirement is guaranteed issue, which means that you can't deny someone coverage if they're willing to pay the premium, and you can't charge them more for their prior health because of their prior health status. The modified community rating means you can charge them based on their age, you can charge them based on their tobacco use, and you can allow for higher premiums for families versus individuals, and it allows for geographic variation in premiums. But those are the only factors that can be taken into consideration, and you can't deny insurance to anyone who's willing to pay the premium.
Mary, on slide 6, you showed pediatric oral and visual care would be covered. Eric wants to know, what about adult oral and vision care? Can you talk about coverage for services that get excluded from the essential benefits package?
Yeah, I think that when it says pediatric, that means that it does not have to include adult oral and vision care. And so if it doesn't have to, That's not to say that no insurer will offer that coverage, but that might continue to be offered as separate benefits, much like employers do today for their employees.
From Alex, with full implementation of the Affordable Care Act, are there any projections about how the community health centers will be impacted? For example, does data from Massachusetts suggest that uninsured persons seeking care in these community health centers will continue seeking care at the centers once their insurance status changes?
That's a great question, and first of all, the federally qualified health centers are going to continue. There's separate funding in the Affordable Care Act to expand the number of FQHCs, as well as to increase the funding to existing centers. It's, I believe, about $33 billion over 10 years. So there's direct increase in subsidies. As far as the care-seeking behavior of the newly insured, I think from both a policy and a research perspective, this is, to me, one of the most interesting questions about the impact of the bill, and we're going to have an opportunity to see on a grand scale never before observed in this country how insurance changes care-seeking behavior among uninsured and low-income populations. My understanding, the evidence from Massachusetts, to the extent that they've looked at this, is that people do not dramatically change their care-seeking behavior because, after all, healthcare, in a sense, is still locally produced and quote-unquote consumed service. Having said that, I believe that will be largely the case for primary care, which is what community health clinics are going to continue to provide to their newly insured populations. I think where we'll see the differences in possibly hospital care and hospital care for elective or non-urgent surgeries, we might see shifting away from public hospitals for some of the more complex cases. Individuals who now have insurance or who are now covered by Medi-Cal may in fact travel across town to seek care at UCLA Hospital, for example, rather than relying on County USC, where they would have gone when they were uninsured. And I do think that we might see some shifting around there. But for the most part, I think people will continue to seek care where they receive it now. And this is, in my conversations with directors of community health centers, what they have been dreaming about for decades, which is suddenly having an influx of patients or a population that now has insurance rather than one that's been largely uninsured.
Okay, we have a question from Becky. She wants to know if you anticipate loopholes in the law that insurers will attempt to use to cancel or deny policies or particular benefits.
Well, that's a good question. All I can say is that based on 30 years of experience as a professional, that the capacity for organizations to identify loopholes in any legislation is almost infinite. So I don't know what the loopholes are today, but I guarantee you that we will find out over the course of the next 3 or 4 years what those loopholes are. I do expect there to be creative attempts to bypass provisions, and my hope is that legislators at the state and federal level, once those loopholes have become identified, attempt to close them as quickly as possible.
And a question from Ken. In California, what do you think will be the funding source for the subsidies?
Well, the subsidies are not unique to California. The subsidies come from federal taxes. So those the subsidies that are available for people to buy insurance in the exchange are federal subsidies that come from tax revenue.
Jerry, you answered this one a bit earlier, I think, but if there's anything you want to add in terms of anticipating a significant drop in patients accessing community clinic services.
Yeah, I don't see a significant drop. In fact, I think that again, in my discussions with directors of community health clinics, they are welcoming health reform because they genuinely believe that they're going to continue to serve the same clientele, but now a significant portion are going to have insurance rather than a significant portion being uninsured. With regard to ACOs, I think, remember, ACOs are another, it's a new acronym, but it's an old idea. There are lots of ACOs already existing in California. I think what health reform will do is it will create new opportunities for accountable care organizations to prosper, because everyone's looking for opportunities for innovation, and innovations that both improve quality and can keep cost growth under control. And I think accountable care organizations have the potential to do that, and they're going to prosper under healthcare reform.
So, Jerry, what will happen in 2013 if states continue to opt out of health reform by refusing to establish health exchanges?
Well, the default is that the federal government's going to show up and create exchanges in the state. And if you think that the political environment is polarized today, just imagine 2 years from now, when the federal government shows up at the door of 20-some states and says, we're here from the federal government and we're here to help you set up your exchange. It's going to be messy politically. I think operationally, it won't be difficult to establish. I just think that it's going to be, well, I can only imagine the political fallout that's going to occur if we reach that stage.
We do have some time for more questions. If you have a question, type it in at the bottom of the chat screen. While we wait, Jerry, can you talk about the basic health plan option and how it might affect the exchange in California?
Yeah, so the basic health plan option, there is a bill that has been introduced in the California legislature to take advantage of a provision of the Affordable Care Act that allows for the state to create what's known as a basic health plan. And the basic health plan would be targeted to individuals between 133 and 200% of poverty. So this is the low-income individuals who are not going to be eligible for Medi-Cal or Medicaid nationally. And under the provisions of the bill, these individuals would be eligible for exchange subsidies. But the basic health plan allows the state the option to create a plan and to contract with insurers or provider networks to provide coverage to this portion of the low-income population, 133 to 200%. The advantage to the state is that they would collect all of the subsidy income, or revenue I should say, from the federal government on behalf of the eligible population, but the state would then be responsible for managing the care of that population. And if the state does pursue this basic health plan option, it means that anyone who is eligible would have to enroll. There would not be an option to opt out of the basic health plan and say, I want to go into the exchange on my own. I don't want to be part of this basic health plan. If the state legislature pursues this option, it's essentially all or nothing under the federal law. So it's a big decision. Potentially could siphon up to, our estimate is, almost 800,000 people out of the exchange And so, it could substantially reduce the size of the exchange, and with that, potentially, the ability of the exchange to be effective as an active purchaser.
Well, thank you, Jerry. Those of you joining us for this webinar probably have gotten emails from us at the school about the health forum that Jerry will be moderating tonight, looking at national and state policy changes brought on by healthcare reform. It will be here at the school at 6 o'clock tonight. We are out of time, so thanks to all of you for joining us. We will continue the conversation October 19th with Professor Jack Needleman discussing the role of nurse staffing and hospital mortality and the implications for keeping patients safe. If you have ideas for future webinars, please type your suggestions on the screen or email us. And if you missed any of our previous webinars, they are all available on the school's website. Again, as we mentioned earlier, please allow a few days for this one to post. Again, thanks for joining us and have a wonderful day.